An integral part of head and neck surgery now is doing the reconstruction. Because of the availability of so many options, we are able to resect bigger tumors and we're able to functionally rehabilitate a majority of these patients. Now, that change has been brought about simply by the use of free flaps. Without free flaps, I don't think we would have reached this level of functional and aesthetic rehabilitation of patients. And free flaps have been around for what, 20, 25 years now. And the techniques are quite well established. And their indications are well established, but everyone raises the flap in a different way, and everybody has their own techniques, or everybody has their own tips and tricks on how they would harvest a flap. So I'd like to present today probably the common flaps, that is radial forearm, ALT, and fibula. Along with that, just to keep you interested to think beyond these flaps, I would show you lateral arm, and then I would show you scapula harvest also. So before we jump into the flaps, so the first flap that we should know, or it's the beginner's flap. Everybody should learn to do the radial forearm first before they do any other flap. And you all know that it's based on the radial artery and the venae comitans. You have a very large skin paddle that you can harvest based on the patient's habitus. You have a long pedicle. The skin is thin and pliable, and you can make it chimeric. By chimeric, I mean not only skin, but you can harvest other components with the radial forearm flap, namely some bone, if you want a radial osteocutaneous, and in some instances, you can harvest a vascular muscle also. That is the brachioradialis muscle can be harvested as a vascular muscle along with this flap. But these are not done because there are other flaps which have given better options. So, but there are still the options available. But before you do that, you must pay attention to the anatomy and the vascularity of the forearm and the hand, because this is one flap if done wrong, or if you miss something, you're going to compromise the vascularity of the hand. So this picture is an important picture that you should pay attention to. Now, the two forearm muscles between which our vascular pedicle lies is the brachioradialis and the flexor carpi radialis muscle. Now, these two muscles are enveloped by a common deep facial sheath. And in between these two muscles, you have the septum, the lateral intermuscular septum. I told you in the previous presentations, the septum is nothing but a facial structure which connects the overlying skin with the underlying bone. And our radial artery usually runs in this septum between the brachioradialis muscle and the FCR muscle. Now, as it runs along its course, it gives numerous branches via the septum to the overlying skin. And the maximum concentration of these perforating vessels is in the distal forearm. And it becomes less and less as you go to the proximal forearm. And as you reach the proximal forearm, you might not have direct perforators going into the skin. You might have perforators going through the brachioradialis muscle and entering the skin. But even if you do harvest a very long skin paddle, the perforators which are coming through the septum should perfuse the entire skin paddle. Now, the radial artery and the ulnar artery are branches of the brachial artery. The ulnar artery contributes to the superficial palmar arch, whereas the radial artery contributes to the deep palmar arch. So prior to harvesting any radial forearm flap, you must make sure that the ulnar palmar arch, or the contribution of the ulnar artery to the palmar arch, is sufficient to perfuse the thumb and the index finger by doing an Allen's test. Now, there are several descriptions of the Allen's test. The way I do it is I put a pulse oximeter probe on the thumb and then occlude both the radial and the ulnar arteries, and ask the patient to clench his fist few times to allow for venous drainage. And after some time, you release the ulnar artery pressure, and within 15 seconds, the pulse oximeter reading should show the waveform as well as the saturation. Now, there are several instances where the patient has an incomplete palmar arch or a completed palmar arch. There are different descriptions where the contribution of the ulnar artery to the radial palmar arch is not sufficient, thereby causing ischemia of the thumb. So you must do an Allen's test and make sure that the ulnar circulation is adequate. And there are very rare instances of changes in the course of this radial artery. Usually, like I said, it is between the brachioradialis and the FCR muscle, but there have been instances, very, very rare instances, less than 1%, where they have an abnormal course over the dorsum of the forearm and entering into the hand. But these are quite rare. So as you can see here, when we dissect the pedicle more proximally, you will have muscular branches to the brachioradialis and the FCR, and all of these have to be clipped. Now, it is a very long pedicle. You get about 10 to 15 centimeters of pedicle length, and usually we don't go beyond the radial recurrent artery. There is a radial recurrent artery which goes in anastomosis over the elbow. We don't have to take that. We can stop our dissection just in front of the radial recurrent artery. And at no cost should you, during your clamping process, damage the ulnar artery. Otherwise, the hand will become ischemic. Now, I will show you the video. The first video that I'm going to show you is the radial forearm flap. So when you do, this is the left forearm of the, is the video visible now?
Yes, sir, it's visible.
Yeah, so this is the patient's left forearm. You have to exsanguinate the arm using a tourniquet or by just manual compression starting from the fingers all the way up to the elbow, and use a tourniquet, because if you do this flap under tourniquet control, the bleeding is less. There is no harm in doing it without a tourniquet. You will have to contend with bleeding, which can be controlled, but it's preferable that this flap is done under tourniquet control. The first thing that you do before you apply exsanguination and tourniquet is to palpate and mark the radial artery, so that when you mark the flap, it doesn't become too eccentric. And then don't try to mark your flap too far into the ulnar side, because you will damage the perforators of the ulnar artery. Usually a flap of 6 into 6 or 6 into 5 would suffice for the tongue and buccal mucosa defects. And then you might make a lazy curved incision for your proximal exploration of the pedicle. Now, whether you start on the radial side, whether you start on the ulnar side, doesn't really matter. I don't know what I've shown in this video, but uh, you know, uh, more recently I start by giving the distal incision first, identifying and tying off the distant part of the pedicle, and then I proceed. But in this video, I've started with the lateral incision. Now, in any flap that you do, you will encounter the skin, the dermis below that, and the subcutaneous fat. And once the subcutaneous fat is incised, you will encounter the deep fascia. So this the dissection up to the deep fascia is safe dissection. You really don't encounter too many structures. You might see small vessels here which can be clipped and ligated, or they can be bipolar. One prominent structure that tends to tent up above the deep fascia is the palmaris longus tendon, which we usually preserve and don't use unless you're doing lip reconstruction. Now, when you do the distant part of the harvest, you have to use a right angle, or you have to use your mosquito or your Kelly and get under the radial artery. The radial artery and the vena comitans are quite thick structures. You'll have to get under the radial artery here, and then you have to suture ligate both the ends. It is useful to keep the flap side radial artery, the sutures quite long, because you can use it for providing traction. Now, this is a part of the flap where we are dissecting the lateral aspect of the skin paddle. As I told you, the skin and subcutaneous can be raised. And here we see the radial cutaneous nerve. Let me pause that for a second and show you the radial cutaneous nerve. This is the radial cutaneous nerve. Now, the radial cutaneous nerve has 2 or 3 branches and supply the anatomical snuff box. Sometimes one of the branches will come in your skin paddle, but that can be sacrificed. You have no other option. Or if it is away from the pedicle, you can still dissect it and leave it down. But don't try to be too aggressive in preserving this nerve, because sometimes you might detach the pedicle from the skin paddle and the entire purpose of this operation would be lost. Always remember, your dissection on the tendon should be above the fascia, and once you come to the territory of the pedicle, you should be below the pedicle. Do not dissect above the pedicle and separate the pedicle from the skin paddle, because you would lose the vascularity and all the perforators. Now, this is a relatively avascular plane just below the pedicle. We are just trying to lift off all the distal attachments now. Sharp dissection is better because if you use blunt dissection with a mosquito, it just takes forever. And usually it can be done with a knife also. As I mentioned, this is the palmaris tendon, which we can use for our lip reconstruction if you want to give it a sling. Then the ulnar aspect of the incision is made. And if you look at the superficial cutaneous veins on the radial aspect, you might find the cephalic and you might want to include that in your flap. On the lateral aspect, you might find tributaries of the basilic vein. I never take the cephalic vein because I prefer to do it to the VC and it just saves time. So if you look at this picture here, you can see none of the tendons have been exposed and it's all suprafascial dissection, meaning the deep fascia is preserved. The only place that you need to dip below and take the deep fascia is between the brachioradialis muscle and the FCR muscle. So that is what we're doing here. We are over the FCR muscle now. And this is an avascular plane that you can get under the pedicle and thereby not damage any of the perforators that are going in the septum. So dissection will also yield and show you numerous cutaneous veins which all have to be clipped. Don't try to bipolar them because they will tend to bleed post-op. Now, this is another thing that you have to remember. Over every tendon, there is the paratenon. Just like the periosteum, there is the paratenon. And this is the deep fascia on top of the paratenon. You have to preserve the paratenon if you want to have good graft take, because you have to close the donor area with the graft at the end of the operation. So do not disturb the paratenon over the tendons. Otherwise, the patient will have tendon exposure. So as we keep raising the skin paddle, you will notice that there are several vessels which go to the deeper muscles, and these have to be clipped and cauteried. You can put the clip on the skin paddle side and bipolar the muscle side. That should be okay. Next, we complete the skin paddle. There is a slight variation. This video was taken a few years back, so there is a slight variation technique that I follow. I don't complete the skin paddle cut here, and I leave the skin paddle attached so that I can do my pedicle dissection and then do the final skin cut. Otherwise, I'll have to handle the flap till the end of the operation in my hand. So it is better to complete the cut till here and just leave this portion of the skin still attached till you complete your pedicle dissection. So you do the skin incision here. Be very careful again, don't enter the space between the brachioradialis and the FCR and you might damage the pedicle. So you have to maintain a suprafacial plane at this point as well. Then the proximal forearm skin incision is made. Once the proximal forearm skin incision is made, the skin flaps are elevated here. Here it doesn't matter whether you expose the tendon or muscle because this is primary closure. But generally there is a plane of loose areolar tissue just above the deep fascia of the tendon which you can raise. The only structure that you'll encounter here is the cephalic vein and the medial and lateral antebrachial cutaneous nerves. So this dissection here can be quite brisk with a cautery or with a knife. The only structures that I mentioned to you, you have to make sure that you preserve. Now, the lateral intermuscular septum becomes less pronounced as we go more into the forearm. So here you'll have to find the space. As you go more proximal in the forearm, the muscles tend to overlap and you'll have to open the space between the muscles. And also the radial cutaneous nerve comes from deep to the brachioradialis and then supplies the anatomical snuff box. So don't damage the radial cutaneous nerve when you're doing dissection in the mid forearm. So again, carefully you have to open the tissues and raise the vascular pedicle. And whatever branches you see that are going to the deeper muscles, you will have to take care of. It is very important to maintain hemostasis on the pedicle, because if you have any bleeding on the pedicle, there might be bleeding in the tunnel that you have created. For example, this is a pedicle to the muscle below. This is a branch to the muscle below. So if you don't take care of these branches well, they will bleed in the tunnel that you create between the oral cavity and the neck, and there is a risk of formation of hematoma, which has to be, you have to be very careful. Otherwise, there'll be vascular compression. So this is further proximal dissection. I don't like to hold the flap in my hand like this, so I just leave the flap with one end attached still, and put a vessel loop under the pedicle, and then do the proximal pedicle dissection. You can go through the pedicle dissection under 5 minutes and get the flap out by giving the final skin incision in the end. So as I mentioned, the lateral intramuscular septum is not very prominent as you go more proximally in the forearm, and the muscles tend to be adherent to each other or overlapping each other. You will have to dissect out the space, and you will encounter several branches going into the brachioradialis, as you can see here, a series of branches. All of them have to be clipped or bipolar, and this forms the basis of using the brachioradialis as a vascular muscle for lip reconstruction. The other thing is you always have to be on top of the pedicle. Don't leave any vascular tissue on the pedicle, any loose cellular tissue on the pedicle. Make sure you're on the pedicle so that the plane of dissection is easy. Otherwise, you might lose track of the vascular pedicle as you do proximal dissection. So the most annoying part, or the time-consuming part of the radial forearm is obviously the pedicle dissection, but the advantages are that you get good pedicle length, and your pedicle lumen, the size of the vessel also is quite big, and it's easy for a beginner to do the anastomosis. So as we go proximally into the forearm, closer to the antecubital fossa, you will see several veins communicating between the superficial cephalic and the deep venous system. Either you clip them and take the pedicle proximal to that, or you avoid them and take the pedicle distally. And once that is done, you have a long pedicle, and then you have to release the tourniquet and make sure that the flap is perfusing. More importantly, make sure that after you release the tourniquet and you place the skin paddle on the hand, the pedicle is not twisted or kinked, because there might be some time before you take the flap and go to the head side, and in that time there should not be any vascular thrombosis. So the pedicle should not be kinked or twisted or turned, and you have to make sure of that. And more importantly, prick the thumb. Always check for vascularity of the hand at the end of the radial forearm harvest, to make sure that there is no compromise. If there is compromise, then you will have to think of using the same radial artery and anastomosing it to this distal end to get the vascularity of the hand back. I've never had a chance like that, but always remember to check the vascularity of the hand. So this is in a sense the radial forearm flap. The donor site is closed with a skin graft. Some people move for example, if you want the skin graft to take in a better fashion, uh, you can always mark your skin island here more proximally, where there is no tendon, but there is muscle belly. The skin graft takes better on muscle belly than it does on tendons. So some people have advised moving the skin paddle more proximally. But the more proximal you go in the forearm, the chances are that the skin paddle becomes thicker, and you might have a shorter pedicle, and you'll have to work with that. So you can move the skin paddle any which way. I prefer to keep it slightly higher, and I also prefer to keep a slightly longer cut stump at the wrist, because if any reason we have to reperfuse the hand, we have a stump to do that. Otherwise, it becomes deep because it goes deep into the wrist. So the radial forearm flap, there are several things that you have to keep in mind. Because it's so commonly done and people do it all the time, we tend to forget some of the basics. It's always good to read about the anatomy and vascularity of the hand, because that will help you, keep in mind what the potential problems and complications that can occur. Now, the next flap that you would normally migrate after doing radial artery, see, in a radial artery flap, there is no perforator dissection, there is no fine vessel dissection. You raise the skin, you raise the pedicle, and then you have the flap. Whereas the next step in microvascular harvest is to do a perforator dissection or a perforator base flap. And the common flap that we use is the anterolateral thigh flap. Now, when you compare the anterolateral thigh flap and the radial forearm flap, both of them have different advantages and disadvantages. The obvious advantage of the anterolateral thigh flap is that you have a large skin paddle that you can harvest. You get large skin territory, especially for composite defects. And the vascularity is such that you can harvest a large chunk of muscle, which is useful, especially if you want dead space obliteration in the ITF, or you want dead space obliteration after craniofacial resection. But the harvest of the anterolateral thigh flap involves dissecting the perforator which supplies the skin. There is no septum here. It is a vascular pedicle going out into a perforator and then supplying the skin. And it is technically slightly more challenging because the anatomical landmarks of the perforator aren't constant. They can vary across length on the thigh, and a preoperative Doppler can help you to localize the the perforator. And the main source vessel that we use is the lateral circumflex femoral artery, and one of its branches, which is the descending branch. Now, this descending branch is covered by the rectus and the vastus muscle, vastus lateralis of the thigh, and the perforators exit the vastus lateralis muscle. They travel through the vastus lateralis muscle and supply the overlying skin. So you have to dissect the perforator through the muscle to the pedicle. In very rare instances, it can directly come to the skin without coursing through the muscle, making the dissection slightly easier, but usually that's not the case. Now, the line where the perforators usually exit into the skin is marked from the anterior superior iliac spine and posterior superior border of the patella. And if you Doppler in the proximal third of the thigh or the mid third of the thigh, you will get the Doppler signal and you can center your skin paddle based on that. Now I'll show you the small video of the anterolateral thigh flap. Now, let me see if yeah. So this is posterior superior lateral patella. This is the ASIS. This is the patient's left thigh. This is the anterior surface of the thigh. This dimple that you see in the thigh of a patient or in your own thighs is the septum that is between the vastus lateralis muscle and the TFL muscle. This is not the septum that we are interested. This is not the space that we're interested. The space that we're interested is between the rectus femoris muscle here and the vastus lateralis, and you can put your fingers and palpate that space between these two muscles. And usually the perforators, you have to center your skin paddle along that line, and perforators can be Doppler just lateral to this line, anywhere in the mid thigh or just at the distal end of the proximal thigh. Now, the actual incision that you need to make is only from here, but I mentioned to you in the last video presentation of the same dissection that sometimes we don't know whether the anterior incision is over the rectus muscle. Because if the anterior incision is made over the vastus muscle, you might lose the perforators. The perforators might go on to the normal side of the patient and your skin paddle will be left with nothing. So one way of doing this is to give a distal exploratory incision near the knee, because this will reveal the tendinous attachment of the rectus femoris muscle. That is the only tendon that you'll find here. So once you know that this incision is over the tendon, you know that as you go proximally in the thigh, you are not going to violate the vastus muscle. So again, this was an old video of mine where I've made the exploratory incision just to show you the tendon of the rectus. But if you're sure that your marking is correct, you can start with the anterior incision. So here you can see once you incise the skin and the subcutaneous tissue, you find the tendon of the rectus muscle, and the muscle just lateral to that is the vastus lateralis. So you continue your incision over your skin paddle, and the skin, the subcutaneous is incised. And once the subcutaneous is incised, you will encounter the deep fascia that covers the muscle. And this deep fascia must be incised. This is the deep fascia here. It must be incised to expose the muscle belly. If you don't do that, again, you might lose out on your perforators. There are techniques where you can do suprafascial dissections, but for beginners, I wouldn't recommend that. So you continue proximally the incision on your skin paddle, and you keep incising the deep fascia as you go along. Now the proximal incision over the thigh is important because your pedicle dissection will be here. So you do have to make a sizable proximal incision. Now, the white structure that you see here is the fascia lata, otherwise the deep fascia of the thigh. This is the rectus muscle, and this is the vastus. The rectus is a diverging bipinnate muscle. And once you put your Alice clips on the fascia lata, you pull them towards you so that you expose the surface between the fascia lata and the vastus muscle. And you will see perforators piercing the vastus muscle and entering into the fascia lata. So here you can see this is a perforator, that is a central artery and two veins, venae comitans, going into the muscle and into the space between. So this is the rectus, this is the vastus, this is the space that will contain the pedicle. Now you might have one perforators or you might have several perforators. The point is, the more distal your perforator, the longer your pedicle. The more proximal your perforator, the shorter your pedicle. Also, the more proximal your perforator, the thicker the skin is going to be. So you might have to be careful on the type of perforator that you choose. You can always thin the skin paddle also of the ALT flap, but the perforator makes a difference in the pedicle length and the thickness of the flap that we harvest. The next step is to lift up the rectus femoris muscle. When you lift up the rectus femoris muscle, you will automatically see the lateral circumflex femoral artery, and that is the artery you see here. Blunt dissection is sufficient. You will be able to, once you lift up the rectus femoris muscle, you will be able to see the lateral circumflex femoral artery. It courses more superiorly to enter the profunda femoris. So our aim now is to free the perforator from its skin entrance here, all the way to its entrance in the pedicle. Now, the muscle that you'll encounter here is the vastus lateralis. As you go medially, the pedicle lies on the vastus intermedius muscle, which lies over the femur. So you'll have to clip a lot of muscular branches as you go along. Use of a self-retaining retractor is good because it gives you traction. Now, once you see the perforator, you start de-roofing the perforator by putting your scissors above the perforator, lifting up the muscle, and then bipolar quartering and then cutting. Now, this is done all the way till you reach the main vessel. It is advisable to use bipolar at its lower settings and a micro bipolar because you don't want to have thermal damage to the perforator. So don't spread, just poke through the muscle, bipolar the muscle so that there is sufficient hemostasis, and then cut the muscle to de-roof the perforator. So depending on the length of the intramuscular course, you will have to de-roof it to a variable length. Here you can see the perforator at the edge of the screen. Yeah, so you can see the perforator here, and the perforator is giving branches to the surrounding muscles. So we have to clip those branches or bipolar those branches to be able to free the perforator. So when you're bipolaring all the lateral muscular branches, you always have to leave a cuff of muscle before you cut it. Because in case the perforator starts bleeding again, it is very difficult to diatherm it because the perforator might get damaged. So don't skeletonize the perforator completely. Leave a cuff of tissue surrounding the perforator so that in case there is some bleed, you will be able to cauterize the muscle and not the perforator to control the bleeding. So once you've unroofed the perforator, then you have to separate it from the sides. The same technique is used, and you go 360-degree all around the perforator from its skin insertion all the way up to the pedicle insertion. Now, the way I do it now is I first finish the pedicle dissection before coming to the perforator dissection, because the pedicle dissection is quicker, but you can do it any which way. But at the end of the operation, you must have a perforator that is totally islanded on the skin paddle. Now, the next incision you make is on the fascia lata or the deep fascia. Make sure you do it from the inner aspect of the thigh. The reason being, if you cut from the skin side, you might become too eccentric when you cut the deep fascia, and you might miss the perforator completely. So what I do is I prefer to cut the deep fascia, that is the fascia lata, the subcutaneous tissue, all the way up to the dermis, and then go to the skin side to give the final cut. Whichever technique, outside in or inside out, make sure your perforator is at the center of your skin paddle. Now the skin incision is completed. You will have to incise the deep fascia and the loose areolar tissues. And once you complete your cut, your skin paddle, perforator, and pedicle will be intact. Now, the more you follow your pedicle proximally, you will see branches which go to the rectus femoris muscle. Now, in my book, I would always prefer to take the pedicle as long as possible, as high as possible, for many reasons, being you get extra length and you get good lumen. The diameter of the vessel also is good for microanastomosis. But there are differing opinions that if you sacrifice the rectus femoris branch, you might not be able to take a future flap based on the rectus femoris muscle. But I usually take the rectus femoris branch and go proximal to that. The other thing about the ALT flap is that the nerve to the vastus lateralis always comes in the pedicle sheath. If you want to dissect it out, that is fine. But I usually sacrifice the nerve, because there are several studies where they have taken the entire vastus muscle along with the ALT flap, and there is no functional problem in patients. So it's an expendable muscle that way. By taking one of the quads, you're not going to damage the patient's functionality. So, and it also helps you to hold the pedicle. You can hold the nerve and do the pedicle dissection. So you get to hold the pedicle in traction for proximal dissection. So the branch to the rectus can be clipped and the nerve can be sacrificed, and you try to follow the pedicle all the way up to the profunda. Now, as you go closer to the main pedicle, that is the profunda femoris, the vein will have a lot of valves, and the walls of the vein there are very flimsy, meaning if you do sharp dissection there, you're likely to damage the veins in that area. So when you do proximal vein dissection in any flap, always try to do blunt dissection rather than sharp dissection to avoid damage to the thin dilated veins which have valves in that area. So this is the final cutting of the fat. And this is the final flap that has been harvested. Now, there are some variations to this whole vastus lateralis ALT flap. Now, instead of you taking bipolaring and unroofing the perforator and skeletonizing the perforator, you can take a chunk of muscle safely by about 2 centimeters inferiorly and 2 centimeters superiorly. You can take a chunk of muscle with the perforator in between that, and just do the pedicle dissection and harvest the flap. That will become a musculocutaneous flap, and it will be bulky, especially if you want to do reconstruction in small spaces. But if you really want to take the muscle, you can take a variable length of muscle. The minimum should be about 2 to 3 centimeters on either side to take into account the curvature of the perforator, and you can still harvest this muscle, and the muscle will survive along with the skin. That is only if you don't want to do a perforated dissection. And in this picture here, you can see that the lateral circumflex femoral is continuing downwards along this flap. So the lateral circumflex femoral has different ways of ramifying within the muscle. So if the pedicle is going this distance down into the muscle, you can theoretically take the entire vastus muscle based on the single proximal pedicle. So you can do a skin with perforated islanding, you can do skin with a chunk of muscle, or you can do skin with a whole lot of muscle, depending on what your requirements are. And if you want to neurotize the muscle for facial reanimation, you can take the nerve to vastus and you can attach it to the stumps of the facial nerve or any other nerve that you wish for nerve coaptation. So usually the defects of 8 centimeters can be closed primarily in the thigh. If you have larger defects, then a skin graft is usually employed. So try to keep the width less than 8 centimeters for good primary closure. The next flap that we will discuss will be the can you see the PowerPoint now?
Yes, sir.
Yeah. So I'll do the fibula before we see the lateral arm and the scapula. So this is a slide that I'd shown you previously. So the fibula is the standard workhorse flap for our mandible and maxilla reconstructions. It's a non-weight bearing bone. We have long bone stock, good vessels. We have dual blood supply, namely the periosteal blood supply as well as the endosteal blood supply. We can osteotomize the bone and contour it to the defect. And the bone height is usually good to take an implant. So there is a lot of good things about the fibula flap that we use. Now the fibula flap is usually harvested along with the skin paddle. And the skin, as I told you, is attached always to the underlying structure, to the bone via the septum. So this is the lateral septum here. If you look at this cross section, this is the fibula. The vessel that supplies the fibula is the peroneal artery. And via the septum, a septocutaneous branch supplies the skin paddle. So when you harvest the fibula bone, you have to harvest the skin, the septum that attaches it to the bone, and the peroneal vessel to get the flap out of the patient. Now, like I mentioned, it is the workhorse flap for any mandible maxilla reconstruction, and whatever other flaps that have been described still pale in comparison to the fibula-free flap. Now, how do you mark the fibula-free flap and where do you find the concentration of perforators? So let us look at the patient's left leg. This is the lateral malleolus that you can palpate at the ankle, and there'll be the head of the tibia there. And you draw a line joining the lateral malleolus to the head of the tibia there. And 2 finger breadths below that is where the common peroneal nerve curves around the neck of the fibula. So you cannot do your osteotomy. So that is a no zone. So you usually leave 5 to 6 centimeters of bone in the upper end and about 4 to 5 centimeters of bone in the lower end to preserve stability to the ankle and to the knee joint. So this is the amount of bone that we can get. It's usually about 10 to 12 centimeters of usable bone. Now, this line also marks where the perforators enter the skin paddle. So it's usually at the junction of the proximal 2/3 and the distal 1/3. If you Doppler this area here, you will be able to get the Doppler signal of a skin perforator. Now, the common mistake people make is that they draw this line far too posteriorly or they draw this line anteriorly. You can always palpate the fibula, and just below the fibula is where the septum enters the skin. So instead of using the lateral malleolus and the head of the tibia, palpate the fibula first and draw the line, because this is the line where the septum attaches to the skin, and this is the line where you will have the perforators that enter the skin. Now, this skin paddle was fashioned differently for a tongue and mandible reconstruction, so don't pay any attention to it. Usually the skin is marked as an ellipse. The unfortunate problem is usually we cannot close the fibula skin paddle primarily. It has to be skin grafted. Don't try to compromise. The important thing is the anterior skin incision should be at least 2 centimeters from the shin to avoid bone exposure of the tibialis anterior and the other muscles. So keep it 2 centimeters from the shin and then mark the anterior skin incision. The posterior skin incision, the further you go, the more likely you are to encounter the sural nerve and the short saphenous vein. They can be sacrificed, of course. And you also always have to understand where your skin paddle goes into the defect. If the skin paddle is for the mucosa, you take the contralateral fibula so that the peroneal surface faces outwards. If it is, for example, if it's a left-sided mandible with a left mucosal defect, you take the right fibula. But if you need the fibular skin for outside skin resurfacing, you take the ipsilateral fibula. The reverse is for the maxilla. So it's not a very difficult dictum to remember. So contralateral fibula is usually taken for an ipsilateral defect of the bone as well as the mucosa. So this is again done under tourniquet, 300 millimeters of mercury pressure. You exsanguinate the limb before you apply the tourniquet so that you have a clean field when you're operating. This is just me thinking about how the skin paddle is going to be oriented. And the important thing is there are some patients where you will notice varicosities or skin changes, tropic changes. Always take a history of smoking and uncontrolled hypertension, because these are patients who will have atherosclerosis. And after you harvest the flap, you will find that the peroneal artery is completely unusable. So we have to be careful in patients who have certain comorbidities which prevent the use of the flap. If they have a lot of skin changes and a lot of tropic ulcers or nail changes, I would be careful, or I would be prepared to do a difficult anastomosis. And I don't usually Doppler for the perforators because I take a longer anterior incision, and usually some perforator is caught in that skin paddle. So the anterior skin incision is made. Now, the important thing here is, as I told you, in all the flaps, you make the incisions of the skin, the subcutaneous, and the deep fascia, meaning the muscle should prolapse out of the wound. The important thing is, in the fibula, the superficial peroneal nerve pierces the deep fascia. You just saw the superficial peroneal nerve there. I will show that to you again. Yeah, so this is a superficial peroneal nerve. So this appears quite superficial when you make the incision. Don't transect this nerve, because the more anterior you go for the skin incision, the more likely you're to encounter this nerve. You can stay suprafacial here and become subfacial beyond the nerve, but be wary that the superficial peroneal nerve does exit much more superficially during your anterior incision. So once you make the skin and the subcutaneous incision, the muscle and the tendon that I'm holding in my hand is the peroneal tendon. So now the peroneal tendon is what is over the fibular bone. So you will have, and this is the septum here, which exits below the fibula. So what we need to do now is hold the deep fascia with an Allis forceps and look for perforators in the septum there. So here there is a good perforator exiting right there, and this is coming from deep to the fibular bone. And there are no other perforators in this patient. So once you identify the perforator, you've got to start skeletonizing the fibula. So to skeletonize the fibula, you first start by removing the peroneal muscle from overlying the bone. You don't do it to expose the bone completely. You cobblestone it slightly. Otherwise, the periosteum of the fibula might get damaged. You can use a knife or you can use the diathermy. I prefer the diathermy because it's quicker. There will be branches to the muscle which have to be cauterized, like the one here and the one here. And the anterior surface of the fibula will come into view. So you cobblestone by removing the peroneal attachments to the fibula, and this has to be done along the entire length of the peroneal muscle and tendon. So once you do that, you see the medial edge of the fibula, and then once you come to the medial edge of the fibula, you'll have to incise the anterior septum. Once you incise the anterior septum, the EDL and EHL muscles come into view. We've still not done this, so I'm sorry about that. We've not finished the cobblestoning yet. So The important thing to remember is when you're reflecting the peroneal tendon near the ankle, don't go in a vertical fashion because you'll transect the peroneal tendon because it curves behind the lateral malleolus. So you'll have to curve your diathermy also posteriorly to preserve the peroneal tendon. This counter traction with the thumb is a good idea because you get enough pressure on the muscle so that it just yields with the diathermy. Then the medial exposure of the fibula is done by incising the septum here. And when you do that, you will expose the anterior tibial vessels and the deep peroneal nerve. So again, use your thumb to give pressure and enter into the medial space there. The retractor usually protects the anterior tibial vessel and the deep peroneal nerve, but always make sure that you don't damage it inadvertently. So the retractors are holding the anterior tibial vessel and deep peroneal nerve. And your only aim in this medial space is to lift the EDL and EHL to expose the interosseous membrane. This whitish structure that you see is the interosseous membrane. And you don't have to separate the muscle too much to expose the interosseous membrane. The next cut that you do is the posterior skin cut. And the muscle that overlies the posterior skin cut is the soleus muscle, and the deep fascia of the soleus muscle must be incised. Be careful not to bevel inwards because you might puncture the septum. Make sure you incise the deep fascia of the soleus muscle, and you might find small branches like this from the septum into the soleus muscle. Some people think that these are musculocutaneous perforators and you have to take a bunch of soleus to protect your perforators. I don't think that is required. These are just perforators that are going into the soleus muscle, which can be clipped. And once you lift the soleus muscle off your septum, the undersurface of your septum, the FHL muscle, the flexor hallucis longus muscle, comes into view. And that is the space we work for freeing the bone posteriorly. So blunt dissection is usually sufficient to separate the soleus from the fibula. You will see small branches going into the soleus muscle. These can be clipped. If you want to take a part of the soleus muscle along the flap, you can preserve these perforators and take the soleus muscle if you want to fill up some dead space. So these are clipped again. And then as you go more proximally, when you encounter the bulk of the muscle, there might be large veins, either from the posterior tibial vein or from the peroneal vein. Be careful here because these veins, once cut, will retract into the muscle and cause terrible bleeding. So if you see a vein, make sure that you ligate it. Now, this is the flap. The skin paddle is in my hand, the undersurface of the septum. This is the FHL muscle, and this is the soleus muscle. And if you look, medial deep under the fibula. So this is the skin paddle here. This is the FHL muscle. If you turn your head and look into the deep confines of the thigh, you will be able to see the posterior tibial nerve. And whatever is medial to the posterior tibial nerve is the posterior tibial vessel. And these are some of the large vessels I mentioned to you that go into the soleus muscle, which have to be clipped if you want to get more pedicle length. So this is one way of making sure that there are intact posterior tibial vessels in the patient's leg by looking under the bone, medial to the posterior tibial nerve. So these branches have to be clipped if you want to do more proximal dissection, obviously, but don't traumatize them because they tend to bleed and cause a lot of problems when we are trying to do proximal dissection. Then you do the osteotomies. You can use a Gigli saw, you can use a reciprocating saw. There is no real vascular structure here that you have to be careful. Unless you go deep and hit the posterior tibial, it's not going to happen. In the proximal part of the fibula, the peroneal vessels are quite close. So you have to make a subperiosteal pocket here. You cannot be cavalier about cutting the bone. So make a subperiosteal pocket, put a malleable retractor between the bone and the peroneal vessel, and then proceed with cutting of the bone in the proximal part of the fibula. So once the bone is cut, use a bone hook and retract the bone outwards and start cutting the interosseous membrane. Once you cut the interosseous membrane, you'll see the lower end of the peroneal vessels here, and these are suture ligated. The muscle above the peroneal vessel is the tibialis posterior, and the muscle below the peroneal vessel is your flexor hallucis longus muscle. So after you have tied off the peroneal vessel exit and you have divided the interosseous membrane, just like how you unroof the perforator in a ALT flap, you start cutting the tibialis posterior muscle to expose the pedicle. Then you cut the FHL muscle distally. If you want to take the entire FHL muscle in your dissection, you put a finger around the FHL muscle and transect it here. If you don't need FHL muscle, you stay close to the bone and transect the FHL muscle like so, while preserving thermal damage and protecting the peroneal vessels. So this is the tibialis posterior on top of the pedicle, the FHL muscle below the pedicle. Once your pedicle is safe and you've dissected it off, you can cut the FHL muscle with diathermy. This is further dissection of the pedicle. Now the question is, where do we stop dissecting the pedicle? So the easiest way to picture this is the moment you see the appearance of the posterior tibial nerve, that indicates the bifurcation of the popliteal or the peroneal artery here. So here you see the appearance of the posterior tibial nerve, and this is what separates the peroneal vessels from the posterior tibial vessels. So the dissection here in this patient would stop right about here, because the more proximal you go, you will compromise the posterior tibial artery as well. So the moment you see the appearance of the posterior tibial nerve, that's where you stop the dissection of the pedicle. So again, more FHL is being dissected off. Recently, in most of the cases that I do, especially if it's a mandible reconstruction, I tend to take the peroneal muscle completely, because it can serve as a lifeboat in cases the skin paddle doesn't bleed, or it can fill up the submandibular dead space. But it's very hard to use the fibula along with the peroneal muscles for maxillary reconstruction, because the amount of space that you have there is just not sufficient to accommodate the muscle. So this is how it would be at the end of your dissection: the peroneal posterior tibial nerve just appearing, peroneal vessels entering the bone, and this is your bone, fibular bone that you've harvested. And there is virtually not much of FHL muscle on the fibula. It's also not good to have too much of bone on the muscle on the bone, because the muscle tends to parasitize the blood supply of the bone. So this is the vascularity being checked at the end of the operation. And you close the skin defect by putting a skin graft and putting a slab. Usually the slab is taken off on the 5th day, but the cast is kept for what, 2 or 3 weeks to prevent the immobilization, to prevent the mobilization of the ankle. Basically, you prevent eversion and inversion, because the more the peroneal tendons keep moving, the more chances are that there is delayed shearing of the skin graft. So you can give the patients a prosthetic boot that will prevent the medial and lateral shearing of the medial and lateral inversion, eversion of the ankle. That will protect the skin paddle, the skin graft, from being sheared on the long term. Now the last two flaps are interesting flaps, because we usually don't discuss about them in most of the meetings, or they're not commonly done. But I like both of them, and I do enjoy doing the lateral arm, especially because it has several advantages. So the lateral arm flap is basically skin from the lateral aspect of the arm, and it is perfused by the posterior radial collateral artery, or PRCA, which is a branch of the profunda brachii artery. Basically, this is a septocutaneous flap, just like the radial forearm, so there's no perforated dissection. And the pedicular section also is quite short. But the pedicle is a very narrow pedicle, and you really have to be a good microsurgeon to do the anastomosis. But the advantages are you can close the skin area primarily. It is concealed and it's relatively hairless compared to the rest of the areas that you have as the flap. And the septum again lies between. So if you look at the arm, you have the biceps brachii here and the brachioradialis here, and you have the triceps posterior. So the septum between these two muscles in the flexor and this muscle in the extensor is where the septum usually exists. And it's about 1 to 1.5 centimeters below a line from the lateral epicondyle of the elbow to the deltoid insertion. So that's where the septum lies, and that's where the perforators run in the septum for the flap. So lateral epicondyle deltoid insertion, about a centimeter and a half below is the lateral intramuscular septum. Usually it's 8 centimeters across, you can close primarily. You can take the territory beyond the elbow also. So people have taken a large territory of skin beyond the elbow, but your final scar will cross a joint, which will make it hypertrophic. And also the advantage is you'll get thinner skin here, but the disadvantage is that you will get a hypertrophic scar. So the skin paddle can be really long, extended distal to the elbow, but I usually stop short of the elbow. The first incision that we make is the posterior skin incision. Again, it is incised skin, subcutaneous, and the deep fascia. And the first muscle that we identify is the triceps muscle. So this is a triceps muscle here. And there is always a loose areolar tissue that you can enter when you work in above these muscles. Now below this, behind this areolar tissue, you can see the septum with the arcade of vessels there. So don't violate that tissue because that is your septum, which lies between the brachioradialis, biceps brachii, and the triceps. So the first step, as I mentioned, is to give the posterior incision, and then you give an incision along the line more proximally. So here what we're trying to do is to separate the biceps muscle from the triceps muscle. So the dissection is between the brachialis and brachioradialis and the triceps here. And you can see that this is the vascular pedicle. The vascular pedicle is really very thin, and it has numerous small branches which can be only diathermied and controlled. And this is the pedicle in the lateral septum between brachialis, brachioradialis, and the triceps here. And as the pedicle goes distally, it enters into the septum. The next incision you make is the anterior skin incision. Again, you skin subcutaneous and deep fascia. Sometimes you might encounter the posterior cutaneous nerve of arm when you make this incision. It's a cutaneous nerve and it can be sacrificed. Otherwise, you dissect the nerve out and preserve the nerve. So this is further incision. Make sure you don't bevel the incision so that you don't harm the septum. Now this incision should lie on the muscles there. The skin is elevated now to expose the pedicle. Now, the reason why most people don't do this flap is because they fear that there is potential damage to the radial nerve. You will see the radial nerve here in just a sec. So you can see here that this is the sorry, I'll just skip back. So you can see here that this is the pedicle giving off branches to the septum to the skin paddle, and we have to proximally follow the pedicle. Now, you can adjust the exploratory incision to where your pedicle is going, so it doesn't necessarily follow this line. So I made the incision slightly more anterior in the direction of the pedicle. So again, you separate the triceps muscle from the muscles of the flexor compartment. You will see branches of the radial nerve supplying the structures here. They can be preserved. So as you go more proximally in the arm, you have to dissect between the biceps muscle and the triceps muscle to expose your nerve, to expose the vascular pedicle. Now, this is the radial nerve that runs in the spiral groove, and you have to be very careful not to damage this nerve. Our vascular pedicle is in very close contact with this nerve and has to be separated. Make sure you don't use monopolar diathermy anywhere in that region, otherwise the nerve can get heat trauma. So further separation of the biceps and the triceps will expose the proximal part of the pedicle. Now the pedicle length is quite short, so you should go all the way up to get the exact pedicle length that we need. Otherwise, it will be difficult for us to do the anastomosis. So this is the pedicle here. We go back. So this is the pedicle here, as you can see. We'll have to bipolar the end of the pedicle once it takes off into the forearm. This is the septum with all the septocutaneous perforators, and we'll have to lift off the septum from the humerus, underlying humerus bone. So now the skin is only attached to the septum, via the septum to the humerus. So what you do now is you will have to expose the humerus by cutting the brachioradialis muscle. You keep a cuff of the brachioradialis muscle, and then you keep a cuff of the triceps muscle surrounding the pedicle. Otherwise, the pedicle might get damaged. So when you're transecting the muscle distally, the end of the pedicle will appear, and that has to be coagulated. So the triceps is also separated from the septum, leaving a cuff of the triceps muscle. And here you identify the end of the humerus bone. Now that is important because you need to expose the humerus slightly away from the septum. So here you can see the brachioradialis being incised and the humerus appearing just below that. And once you have the humerus exposed, you have to do something called a subperiosteal lift. You have to lift off the septum along with the periosteum to protect the septum. Otherwise, the septum can get transected. So you do a subperiosteal lift from the humerus on both sides. It has to be done both on the side of the brachioradialis as well as the side of the triceps muscle. So this is the final flap that is in my hand. This is the radial nerve going between the brachioradialis. You can see this is the pedicle. It isn't as big as the radial artery. The lumen is quite narrow. So you will have to have a lot of practice in microanastomosis. But this is a very good flap because it is slightly thicker than the radial forearm, but not as thick as the ALP. So it gives bulk for slightly bigger defects of the tongue. And the donor side can be closed primarily. So these are some of the advantages of the lateral arm flap. And once you start doing it, it tends to be your favorite flap for tongue defects, for probably hemiglossectomy tongue defects. The last flap that I want to show you, which is a flap that is gaining a lot of traction in reconstructive circles, is the scapular flap. Now, the alternate to the fibula used to be the DCIA, but the DCIA does have a lot of morbidity associated with it. There are problems with pedicle length, and there are problems with getting, the right thickness of skin or the right thickness of muscle to close off defects. The scapula is quite good because it has, some of the advantages that the DCIA doesn't have, and it does not have the pitfalls that the DCIA has. The only problem with the scapular flap is that it has to be harvested with the patient in a lateral position. So before you start thinking about the scapular flap, you look at the anatomy of the scapular flap. So if you look at the scapular bone posteriorly, we have something called the circumflex scapular artery, which goes over the scapula. And this is a part of the subscapular artery, which is a part of the axillary artery. Now, the circumflex scapular artery has three important contributions. There is a transverse branch, which is cutaneous. There's a descending branch, which is cutaneous. And there are bony branches, which supply the lateral border of the scapula. And where does this circumflex scapular vessel enter into our area of dissection, that is called the triangular space. That is the space between the teres minor muscle, teres major muscle, and the long head of the triceps. So the patient has to be in a lateral position. You can palpate the long head of the triceps, the teres major, the teres minor, and this is where the circumflex scapular vessel emerges onto the dorsal surface of the scapula from the subscapular artery. So the only disadvantage is that you have to reposition the patient, so there is some amount of time involved. But the advantages are you can harvest a skin paddle either with the transverse branch or with the descending branch, or you can harvest two skin paddles in this flap. And the skin paddle is not limited in its movement like the fibular flap. The fibular flap, the skin paddle movement is limited because of the septum between the skin and the bone. That doesn't allow you to move the skin paddle in different directions. Whereas in a scapular flap, there is a wider range of movement that is possible because these are perforators going into the skin and not necessarily through the septum. So this is a very short video of the scapular flap. So this is a patient's left shoulder, and the triangular space, as I mentioned, is between the teres major, teres minor, and the long head of the triceps. And you can actually Doppler that space and for reference using a handheld Doppler. And you can mark a skin paddle either inferiorly like this or transversely. So in this case, we used a skin paddle along the direction of the bone of the scapula. So we're using the lateral border of the scapula. We identified the Doppler signal. The first incision here is the skin and the subcutaneous, as I mentioned, for any flap. The skin and subcutaneous are incised. And the most superficial muscle that you'll encounter is the latissimus dorsi muscle. It's a large muscle, large fan-shaped muscle, and it tends to overlap the teres major and teres minor. So it is very easy to get lost when you're doing the distal raising of the flap, but stay in the subcutaneous plane in this facial loose areolar tissue in this facial space and start raising the skin paddle. Now this muscle here most distally is the latissimus dorsi. Above that will be the teres major muscle. So we are now lifting off the skin island from the teres major muscle just until we reach the triangular space. You don't want to skeletonize the perforator. You want to leave the perforator with some facial tissue around. So this raising of the skin island is done just until we see the upper border of the teres major muscle. So we are entering the triangular space now. And then once you reach the triangular space, you know that the circumflex scapular artery is going to give the perforators to the skin. Don't try to skeletonize the perforator in this area because you might damage the perforator. Once you identify the muscular triangle, you dissect into the axilla. And once you dissect into the axilla, you will start seeing the origin of the circumflex scapular artery and the subscapular artery. So once you've identified the pedicle there, you start skeletonizing the lateral border of the scapula. You don't skeletonize it too much. You leave a cuff of teres major muscle attached because you want to protect the periosteal blood supply. So the muscles on this side will be the infraspinatus muscle, which you'll have to retract by incising, the serratus anterior at the angle of the scapula, the supraspinatus above the spine. So all of these muscles have to be detached from the scapula so that the bone cuts can be made. So this is a skin paddle. This is the teres major and the latissimus dorsi that have been retracted. This is the lateral border of the scapula that you see here. This is the pedicle entering into the skin. And the undersurface is the subscapularis muscle, which have to be, again, using a diathermy, you have to reflect the muscle off from the deeper aspect of the scapular bone. The bit of serratus anterior is still attached there. So once you've done the separation of the muscles, then you can proceed with pedicle dissection. The vessels are quite flimsy. They're not as thick as the radial artery or the peroneal artery. So you'll have to be very careful. By moving the arm, by free draping and moving the arm, you'll get more visibility and more access into the axilla. And then you'll be able to dissect more of the pedicle. Then once that is done, the lateral border of the scapula is cut with a reciprocating saw, making sure that you're protecting. So the skin paddle is retracted anteriorly, the pedicle is anterior. So you start from posterior and start cutting the bone about 1 centimeter below the glenoid so that you don't damage the shoulder joint. So this is the bone that's been cut, and the bone vascularity is also checked. So you get bone and you get an independent skin paddle which moves in generally a decent direction. The pedicle length is about 4 to 5 centimeters, and this is a good flap to do, especially if the patient has problems with the fibula because of atherosclerosis or peripheral vascular disease. Usually these vessels are not affected by comorbidities. So it is an interesting flap, slightly difficult to do for beginners, but has several advantages which give it specific indications for mandible reconstruction. So these are the flaps that I wanted to show today to you. I'm happy to take any questions that anybody has. Yeah.
Okay. Question by Dr. Vinay. Is there any anatomic variation in forearm flap? I think radial forearm flap.
Yeah. See when I think Cormack or Lombardi, one of them did an anatomical study of about 700 cadaveric dissections of the radial artery anatomy, and they found no variations. But there are some variations that you have to remember. The variations can be either variations in the hand or variations in the forearm. So variations in the hand can be incomplete communication between the two different palmar arches. So if you there is something called the complete palmar arch, there's something called the completed palmar arch. But basically, if your ulnar collateral supply is not good, you might have ischemia of the thumb and the index finger. Second thing is there can be something called the persistent median artery, which can also give additional supply to the thumb and index finger. And in certain instances, the radial artery has been found to go dorsally over the extensor pollicis. So 99.9% there is very rare. It's a very rare flap to show variations. But Erkin does mention very less than 1% problems with the radial artery anatomy.
Again, by Dr. Vinay. How many perforators should we include in an ALT flap?
A single perforator is sufficient, usually. Because the angiosome of the thigh is such that you have one in the proximal thigh and then the next one is near the knee joint. So you can take two angiosomes with one perforator. So basically you can have just one. But there are several things that you have to remember. If the patient is a smoker, if the patient has other comorbidities, or there can always be loss at the edge of the flap. So whenever you harvested the flap, make sure the edges are trimmed, the edges are bleeding, so that you don't inset compromise vascularity. So, and don't use diathermy, extensive diathermy at the edges, especially if you're taking a very large flap. So people have done 20 by 20 centimeters, 20 by 10 centimeters ALT with a single perforator. I don't think there's any, cutoff like that. But in smokers and in patients who have comorbidities, there are chances that there is a peripheral loss. And this peripheral loss is bad because that is what is sutured to the mucosa or the skin. So always trim the edges, make sure that they're bleeding, and then take the flap.
Okay, sir. There are a couple of questions. There are a couple of requests to show MSAP flap and the supraclavicular flap if possible. Or do you take the questions and?
You can see the supraclavicular flap on my YouTube channel. I don't think I have put the MSAP video yet. I will edit the MSAP video and put it on the YouTube channel.
Okay. So the other question is again by Dr. Vinay. Sir, how to orient fibula in maxillary reconstruction, the bony fixations?
So always the plating surface is the peroneal surface. So that has to face outward. The peroneal surface has to be medial, inward.
Okay.
Is that what you wanted?
I think so, sir. How do we orient it? Yeah, that's what.
The peroneal surface is always the plating surface. Peroneal
Uh,
means where the peroneal tendon. The
okay.
peroneal vessel surface is always the medial surface, so that you don't damage it when putting screws and plates and all that. And then
Okay.
you use the mandibular teeth as a guide, and then fix the maxillary, the osteotomies of the fibula, and then it has to have some bony contact with the zygoma. So the plate will start from the zygoma and go to the intact normal maxilla with the peroneal surface facing outward.
In case of bipaddling of ALT,
Yeah.
you prefer only one perforator or multiple perforators?
So it depends on what you have. If you have multiple perforators, you take multiple perforators. There's no harm. It also allows you to divide the two skin paddles into two, skin paddle into two, and then avoiding the de-epithelialization and all that. Now the question is, I would prefer to have the perforator on the outside skin paddle because it's easier for it to drop down into the neck for anastomosis. So one perforator is sufficient. I don't think you need to have more than one perforator.
Next question is by Dr. Jareen. In what cases would you use a submental flap?
So submental flap is okay in old patients where no other flap is possible. If they are node negative, there are a lot of reports of people using it for tongue and buccal mucosa. So I would use it in a very old patient where there is a quick tongue resection who's node negative. That's probably the only indication for a submental flap now. The other things that I've used submental flap are for cheek defects, like cutaneous defects after parotid or something like that. You can still use it for resurfacing cheek defects or skin defects here. So from a mucosal point of view, tongue, uh, maybe buccal mucosa and a edentulous patient, and cheek skin. But in a node positive patient, when there are other options available, I just don't do the submental flap.
Okay, sir. So next question is by Dr. Abhimanyu. How short is segment you can make in fibula?
2 centimeters.
Okay.
Because that is the shortest. Some books have said 1.5, but it's very difficult because I think 2 centimeters is the shortest you can use the fibular segment with intact periosteum. But if you have the FHL muscle taken totally in the flap, then even 1.5 is okay because you'll have some blood supply via the muscle attachments also. But I wouldn't do anything less than 2 centimeters because high chance of bone resorption and avascularity of that bone, that 2 centimeter segment of bone.
Okay, sir. So next question is by again Dr. Abhimanyu.
Yeah.
In case of a pediatric fibular reconstruction, which age do you take as cutoff?
Which age?
Yeah. At what age do you, I think you will avoid? At what age?
We have done for 4 or 5 year old patients and all that. I don't think it affects too much. There is no age. The youngest patient I've raised, I think, is about 4 or 5 years old. It's very easy to raise because it's very quick. The leg is short, the pedicle dissection is short, everything is short. So you'll finish in 15-20 minutes. So I don't think there is any age cutoff. At least I'm not aware of any age cutoff for fibula.
Okay, sir. He was asking if it would be great if you could explain the growth pattern of fibula in pediatric patients.
The fibula doesn't grow in our transplant, in our fibula flap reconstructions because we're not doing a growth center transfer.
Oh.
The fibula that we take for our mandible and maxilla, where they don't incorporate the growth centers. We leave behind the growth centers in the parts that are left behind in the leg. So the fibula doesn't grow. It's the native mandible that grows. The fibula might grow in girth, like, height,
Yeah.
but it doesn't usually grow in length because there is no growth center that you're transferring. So in a pediatric patient who's reconstructed the fibula, what you have to do is put the fibula, hope that the normal other facial bones grow and accommodate that space. And you should remove the plates and screws as early as possible because they tend to restrict the growth of the face. So once the bone is set, and take the patient for a secondary procedure and remove the plates and screws.
Okay. So next question is by Dr. Shubhra Sharma. How do we
Yeah.
salvage a central arch fibula?
Do another fibula.
Okay.
Otherwise, there's not much options. The pec major with rib, pec major with sternum, they are not very robust flaps. And a lot of people put plate with PMMC, which is another disastrous option, because the plate and pec major will cut through and plate will fracture and it'll become hell after that. So if you have a central arch failure, do another fibula. Otherwise, pec major with sternum, pec major with rib and all is not very. It's a very difficult situation to be. We've done second fibula, or you do some other, but the problem is you cannot be without reconstructing the central arch. It's such an aesthetic and functional problem. So whatever it is, you'll have to reconstruct it.
Next question is by Dr. Manu. How much time delay is permitted between flap harvesting and anastomosis in radial forearm and prefibular flap?
Radial forearm up to 4 hours, that is stretching it. Skin flaps will survive for 4 hours. Bone flaps even longer. So I would say 2 to 3 hours is the time that you can push both the radial forearm and the fibula. But the question is, if you're taking the fibula with muscle, if you take the fibula with the FHL muscle, the flexor hallucis, muscle has a very short ischemia time. The problem with muscle is that there is something called reperfusion injury. The muscle will perfuse, but there will be a lot of internal ischemia and release of toxins and necrotic products, which will cause the flap to die out in the long run. So any muscle flap that you do, you have to make sure that the ischemia time is the shortest, especially if you're doing like functional muscle transfers. You want the ischemia time to be as short as possible so that the muscle retains function and there is no reperfusion injury. But skin only and bone only flaps 2 to 3 hours, 4 hours maybe.
So our next question is by Dr. Vinay again.
Yeah.
Is it required to remove the whole bone or just skin sufficient to divide the skin paddle if it's not flap is not viable?
So it depends on what indication you have done for. Suppose let's say you've done it for a benign pathology. The biggest, like, you can use static bone grafts if you're doing ameloblastomas or benign things where patients don't receive radiation. So in those cases, you can leave the bone behind, give some soft tissue cover to the bone so that the bone is not exposed to saliva. And patient also has got no radiation. So usually these patients, it'll be okay. But in malignancy patients, if you leave behind the bone, there is a concept that you wrap the bone around with pectoralis major muscle or some vascular muscle so that the muscle provides some vascularity to the bone. But all that doesn't work. If the skin paddle is gone, the bone will die because of desiccation by saliva. So it is better to remove both, plan for another flap reconstruction, and get the patient through radiation. But like I said, if it's for a benign condition where there is no radiation, you can still use it as a bone graft. People have used up to 6 centimeters of bone as bone graft, but you should be able to close mucosa over the bone. But if the patient is going for radiation, don't leave anything like that behind.
So, another question by again Dr. Vinay. Is the double barreling fibula safe? And if it is safe, what should be the defect size?
Double barreling is safe. The only problem with double barreling is that between the segment of the bone below and the segment of bone which goes and sits as a double barrel, you'll have to remove a long segment of bone to accommodate that arc of the pedicle and to accommodate the bone on top of the bone. So there is nothing like size of the defect. The defect can be anything, provided you have long enough bone that will accommodate you removing. You understand, right? When you have a fibula like this, and it has to go on top and sit on the same fibula, the other segment, and in between these two segments, you'll have a curved pedicle. Now you have to have a sufficiently long fibula for you to be able to remove that intervening bridge of fibular bone and then bend it over itself. If you have a defect that is from the condyle going to the angle of the other side, it's impossible to do a double barrel. But any hemimandibular defect, we should be able to use the distal part of the bone for double barreling. It can be done. But more important than double barreling is you can plate the mandible slightly higher so that the fibula is also slightly higher. That gives you in between double barreling and putting it at the lower border. So it basically depends on the length of fibula that you have left and the size. If it's a very long defect, like I mentioned, from here to here, then there is no point double barreling. And you should know where you're double barreling also. Usually double barreling is done in the anterior or just lateral arch here. So you should have enough fibula to remove with the vascular pedicle intact and a distal fibula that can be flipped over so that the vascularity of the distal fibula is preserved.
Okay, sir.
People have done, without the distal pedal having any vascular pedicle, which is the periosteum, people have done. It works, but it depends on the amount of fibula that you have in your hand.
Sure, sir. So next question is, in case of dental implants, would you prefer it primarily or do it at a later date?
There's evidence now which is coming in which suggests that primary dental implants are better than implants after radiation. That is, implants after radiation have a higher chance of failure, have a higher chance of osteoradionecrosis. Patients have mucositis, difficulty mouth opening. A lot of problems are there after radiation. So there is a lot of discussion and a few papers that have said that primary dental implant placement is good, whereas prior to radiation. Amrita, we don't place for malignancy patients for cost reasons and the general outlook of patients and things like that. But in our benign cases, we generally do secondary, like once the patient's bone is healed and we stage it, you do a thinning of the skin, vestibuloplasty, create the sulcus, then put the implants and things like that. So if you want a purely academic answer, what is the right thing to do? Primary implant is the right thing to do. What we do is we do secondary implants.
Okay, sir. For now, that's it, sir. Those were all the questions here. So I thank you again, sir. Thank you for giving us a great lecture. And there are many congratulatory messages too.
Thank you for the opportunity. Thanks.
So again, next week we'll meet for the partial laryngectomies.
Yeah, we can. The partial laryngectomy is a lot to discuss. So we can. Yeah, we can. Vertical, we can discuss a few. Horizontal, we can discuss a few. Yeah, we can discuss. Should be okay.
Sure. Thank you, sir. See you.
Thank you.